This conference will now be recorded.
What I should have told you before I started the recording is anybody who doesn't want their face to be seen or their name to be seen is very welcome to change it. We don't want you to leave. We want you to be comfortable. So today is the 6th of April, and we're gathered in the high-risk recurrent and advanced AnCan virtual prostate cancer group. Rick Davis, am leading tonight, and Len is here to help me, and anybody else who cares to help. We got a bit of a full house, 47. I was predicting 50 to Bill Franklin earlier on, so I'm not far off. I bet you we have over 50 by the time we're done. And as most of you knew, got to be here in the first 10 minutes if you would like to claim some time, and we have 11 people who need time and 1 new gent. So for the benefit of the new gent, what we generally do is we try to make you welcome. We hope we make you welcome. We don't try, we do our best. And we give you the right, a priority right if you would like it. You don't have to take it. Some people are not comfortable doing that. And I have a bunch of questions. I ask you to follow through with me because we have them in a certain order and it just makes it easier and quicker for us to go through. So, okay. David, we're ready. We have at least 2 other satellites. No, Seattleites. We have at least two other Seattleites that I can see in this room right now, and there may be more. So who knows? All right, we're up to 48. I'm looking good on. I didn't make a bet with Bill, but I'm looking good on my bet. Have you? I'm going to ask you because if so, your last name will be in the group. But have you signed up to receive the reminder, David?
Yes, I have. I've seen a couple of previous recorded messages, so I have a general idea how these go.
Okay.
Rick, excuse me, Rick, did you do the acknowledgement of our sponsors yet?
Oh, I forgot. Thank you, Len. Thank you for pointing it out. Well, there aren't that many anymore. Yes, we should have acknowledged our sponsors who are, and I should have known this because I've been working on the Novartis sponsorship all day. It is a bear. I've got to do 5 different applications this year to Novartis. It's crazy. Our sponsors are Novartis, Blue Earth, Telix, and Foundation Medicine. That's it. It's a short list, I'm afraid. Thank you for reminding me, Len. So, David, your email is in the. You signed up and it's in. You will need to give me a clue either privately, and I'll just tell you the chat window is next to the 49. Those 2 little boxes, and you can send a message to me directly or you can send it to everybody, but you'll have to give me a clue because we got a bunch of David D's, so I won't know what email to associate with you. So you'll have to help me. You'll have to help me out. You can put it in again. You can just give me a clue, but we'll figure it out. Okay. How old are you, David?
69.
Okay. And you live in Seattle?
Yes.
That's the easy part. And what year were you first diagnosed?
2019.
Okay. And when you were diagnosed, what was your Gleason score and your PSA back in 2019?
Gleason was 6, just a shade over 6. Biopsy when it was first read was 4 and 4, and I decided to get a second opinion. It was read at 4 and 5 for 9. That was at UW Medicine, Fred Hutch.
Okay, hold on a second, because you said your you said your Gleason was 6. You meant your PSA was 6, I think.
Sorry, PSA 6.
Okay, because I was going to say, you fooled me. Okay, so your PSA was 6, and you had your biopsy reread, and it came out eventually at what?
9.
4 plus 5 or 5 plus 4?
4 plus 5.
And was it reread by either Dr. Epstein or Dr. Zhao or locally?
Locally.
Okay. And were you attending? Well, it was Seattle Cancer Center then, wasn't it? Or was
Yes.
it hot? Yes. Well,
Not
is that
yet
what
much. It was still the Seattle Cancer Care Alliance.
Yeah. And
Now,
and that's where you went?
Yes.
Great. And who were you seeing there?
The urologist, Dr. George Shade, originally for the surgery, and then Heather Cheng, the GU oncologist.
Yeah, we know her. We have some other people. We have a few people who are with Dr. Cheng. So before you commenced, did they do any scanning?
Yes. It was not a PSMA scan at the time. I think they scanned for bone. They did a bone scan.
Okay.
Didn't find anything.
Yeah, there were. I mean, it's interesting. There were PSA scans, and they were particularly designed for people like you who might go into surgery or change their name. It was either Falcon or what was the other one? There were two. I forget them. One was called Falcon. I forget what the other one was called. Eagle, maybe, or something like that. And it was a trial that UCSF was running with Peter Carroll, and Hutch was participating in it, but you didn't get it.
I tried to get a scan during the onset of COVID at UCSF, but in that trial, but they all shut down. I couldn't get it.
Yeah. So it sounds like you chose surgery.
Yes, sir. Surgery, and then there was there were margins. So there was extra nodal extension and right seminal vessel was positive for invasion. And so I had a PSA shortly after surgery, and it was small, but it was there.
Okay, so I'll come to that in a second. So they classified you as T3B?
T3B, yes.
Okay. And what was that PSA right after surgery?
I don't have it. It was pretty low. It was,
okay.
I believe it was below 1, but the fact that it was there got us moving to make plans for the next step.
Right. No, I mean, we'd hope it was well below 1, but I was just wondering if it was, just barely or it was enough, but the PSA was up. Yes. So how did you address that initially?
So the plan was we set up for the salvage radiation and ADT on top of that. Started the ADT roughly a month before the radiation, and that was Lupron.
Right.
and was delayed somewhat in getting both of those treatments set up while the Hutch was figuring out how they were going to process cancer patients during COVID.
Yeah. And how much radiation did you get? How many? First of all, I'm figuring it was probably IMRT, and how many sessions?
38 sessions. I don't have the total radiation amount handy.
That's okay. And who gave it to? Who was the rad-onc?
Dr. Ma.
Okay, all good. Now today you'd probably get abiraterone with that, but back in 2019-20, was the salvage radiation already in 20, or was that still in 19?
That was 20.
Right,
summer of 20.
Yeah, they probably would give you abiraterone with that, but they weren't doing that back then. So yeah. Tell us now. Well, let me ask you a couple more questions, and then we'll go on. I know this is redundant because your doc is Dr. Cheng. Did you have any genetic testing before?
Yes.
And was it just germline, or did they do any somatic testing too?
I'm not sure. The first one, I believe we checked for BRCA and that was negative.
Okay.
I just this past month had the Oncoplex gene panel done. I don't know what that is. Maybe you do.
No, I don't actually. And did they do that from? I don't know if that's a somatic test or if that's a. It can't be an inherited germline test. Somebody, Lennon, look up.
They took it from a saved lymph node, apparently.
Okay.
Collected during surgery.
Okay. Yeah. So that's some sort of a somatic test. And you were negative for germline.
Yes, that's BRCA.
Yeah, and then BRCA is one of them, but it's anything you might have inherited. That's the study that Dr. Cheng was a principal investigator on. So
correct. Yeah, it's not hereditary.
Right.
Rick, Oncoplex is University of Washington Cancer Care gene sequencing panel.
But what? Okay, somatic though, right?
Somatic.
Yeah. And have you had any results back from the somatic?
Yes, I can't make sense of much. It does say positive for PTEN loss, biallelic, and additional alterations, negative for microsatellite instability with low tumor mutation burden, 1 per MB, and low sample quality limits the study, see interpretation.
Okay. I mean, that's enough just to know that you're P10. And P10's really prevalent. I just read about this. I think it's 30% in people who have somatic. There's a very high prevalence of P10. Okay, we have your contact details. How did you hear about us?
Through the Mayo Clinic Connect, Jeff mentioned that he sits in on these, so I thought I'd try it too.
Yeah, thank you. All right, why don't you tell us what's been going on with you since 2020?
Okay, after the radiation, initial salvage radiation and ADT, that was a 6-month of ADT. I was clear for several months. Then the PSA started creeping back, and we did a second round of ADT and SBRT. This time Lupron with abiraterone. and let's see, that was 23, early 23, and then shortly after that, we had a PSA rising again. They did a PSMA scan and found 2 lymph nodes this time. They used the targeted radiation to get the lymph nodes, with this time without hormone therapy, because I was told that the difference between doing it with and without ADT was minimal, and I was had a lot of things I really wanted to do in my life that I didn't want to do under ADT.
So let me just ask you a couple of questions here. The first time when the PSA re-arose, how high did it get? Over 1, under 1?
It was still under 1.
Under 1, okay. And where were when they used the SBRT, where were they focusing? Where were those lesions?
Abdomen, upper abdomen.
Okay, so they were still lymph nodes.
Yes.
Nothing in the bone yet.
No.
Nothing seen in the bone. Great.
Correct.
And then when did you come off the abiraterone and the Lupron?
That was a 6-month course. That was in 23. So it was been the end of 23.
Okay, so the first time, when did you come off of the abiraterone? Or the Lupron?
That was 6-month course as well.
And that was 6 months. Okay,
Yeah.
So you've never been on relatively continuous hormone therapy?
Correct.
Okay. So now we're up to 2024 and your PSA rises again, yeah?
Yes. Another PSMA test, found 2 lymph nodes, SBRT to those with no ADT. I had 3 months after that before the PSA came back. And it got up to 3.0. And at that point, we started ADT with Orgovyx and nothing else at this point. That was October 25.
And did they do another PSMA scan?
Yes, multiple 4 or 5 lymph nodes, one near my heart, one under my there's a nerve bundle under my clavicle, and one in my neck. Radiation oncologist said we could get those with some risk, but you're probably better off with just shifting to systemic from this point forward, and that's what we did.
So back in October 25, you saw several lymph nodes, several nodes, and again they were all soft tissue, no bone, right?
Lymph nodes, correct? No bones.
Okay, but all over. And so Dr. Cheng put you back on Orgovyx, but with no second-line ARSI?
Correct. We're going to talk about that next, my next meeting next appointment with her in 2 months.
Okay. So do I have all of your treatment up to date now?
Yes.
Okay. You've never been on any bone strengtheners? Have you had your bone density measured?
No, there's an order in for it. I'll get it in June.
Okay. And your testosterone, does it always go down nicely when you start the hormone therapy?
I believe it's below 10.
Now, okay.
Yeah, now. And my PSA last was 0.3.
0.3. Okay. And when was that? How long ago?
That was 2 weeks ago.
Okay. And how long had you been on the Orgovix when it was 0.3?
5 months.
Okay. So, and what questions do you have for us? I have a couple of thoughts. I'll give them to you, and then I'll throw it open to the guys.
Okay. Well, my first question is, Dr. Cheng is suggesting, at least discussing, making this a 6 or 9 month course and having an ADT holiday. I'm pretty nervous about that. The more I read and learn and understand about advanced prostate cancer. Did I mention cribriform and IDC?
No, but I'm writing it down right now.
I have both those.
Okay.
More signs are pointing me toward, I think I need to be more aggressive. And so I'm in search of additional information background as to, maybe it's appropriate that I go on a ADT holiday, but maybe it's not. I don't think I know enough.
So, I mean, you're sort of focusing on what I've seen all the way along. And I don't know if, Steve, you don't see, I know who you see. I know who sees Dave. Dave sees. Guy who's been coming to us for ages, who's in Walla Walla. He was in Seattle when he started, but he's moved to Walla Walla, and he sees Dr. Chang, and we've got a couple of others. I don't think she's ever. I mean, for somebody who's T3B, cribriform, IDCP, she's never really given you a fair shot of hormone therapy. And I'm not a doc. I can't give you medical advice. I can tell you what I've seen. And what I've seen is that when people have more aggressive forms of prostate cancer, and yours was plenty aggressive, because if nothing else, 4+5 with a PSA of 6 throws up red flags because the PSA is so low. So that tells me that your PSA or the type of prostate cancer you had was probably variant from the get-go. Otherwise, you would have had a much higher
PSA. Uh-oh, it just froze.
Sorry, guys. I should be back right now. I can. It looks like I'm going to be. So, Len, be ready to jump in. It looks like I'm going to be having some internet issues here. I'm going to switch my camera off, at least for the time being. So, and I always feel, and people sort of say, no, you don't need it, but I always feel like you got to do 18 months to begin with, off the bat. And today that 18 months would be with abiraterone, although for you it's, at the time it wasn't, but then she brought it in quickly. I think I know what I would do is I do hormone therapy with first line Orgovix and second line something, probably Abby, but maybe not. Maybe Nubeqa, maybe daro, and I'd do it for 18 months, and I'd see if that really got to grips with what was going on. That's how I would deal with it. So your instinct confirms what I personally would do. But let me go to Len, and then from Len, put your hands up, and we'll stick with you for another 10 minutes or so.
Okay.
And then we need to move on.
So,
Just
David, did they discuss the possibility of chemotherapy with you?
in general, yes, not immediately. It was mentioned as a down the road option for me.
Okay. And there is a compound, it's still in clinical trials, I think phase 3 for prostate cancer. It's been approved in breast cancer for P10 deletions like yours, capivasertib. Did they discuss that at all?
No.
Might-
Do you
might be
have the name of that trial?
Sorry?
Do you have the name of that trial?
I don't have the name of it, but I can find out, or someone can find out.
Okay.
Yeah, it's in phase 3. It's shown effectiveness in breast cancer. There are some side effects, but probably not as bad as chemo.
Okay.
Yeah. Anybody else want to comment or ask David anything?
You got a couple of hands up, Len.
Oh, I see.
Jeff
Okay,
Markey.
Jeff Markey,
Yeah,
and then Jim Marshall.
I just was going to mention that this wasn't brought up, but the fact that after 5 months on ADT, you're at a 0.3 really points to the fact you need to get on that ARPI, either daro or Abby.
Yeah,
I need to correct here. I just double checked my my last result. It was 0.09 in January of 26.
okay, that's a little better because you're under 0.1. I mean, I had actually ringed and circled that, but if you're at 0.09 after 6 months, you know, you're
that was after 4 months.
sorry,
and
after
then
4 months. Yeah.
And I'm sorry. Here's even later when it's
Gold number, you
0.05
said.
in March.
Say that again, David.
I've just found another one, 0.05 in March of this year. So just last month. So that's at 5 months was 0.05.
Okay, so 0.05 at 5 months, I think says yes, you're responding. So I was also concerned like Jeff, but we cleaned that one up. I'm sure Jim Marshall wants to ask, are you a vet? Are you a veteran, David?
No.
Okay. All right. Anyone else have, I mean, I can see why Len would ask, because probably at this point, there may be enough reason for you to try some chemo. But she's really taken you so gently right the way through. I can't see her going for chemo. And I honestly feel like you need to do a decent stint. The capivasertib trial is called Capitello, and I'm going to put the link in the chat window for you. Hold on a minute. Here we go.
Rick, I would alter my opinion to agree with yours that he should continue with hormonal therapy. I did not realize that, well, David hadn't told us how well his PSA was being brought down by hormone therapy. So it's premature to do anything beyond that. I would agree.
Right. So I put the trial in there. I'm not going to put more information because if you click on that, it'll bring it up. But it's a trial with abiraterone for metastatic hormone-sensitive prostate cancer, which I probably would say you are because you're definitely responding, and a P10 deficiency. Let me see if it's in Washington and South Carolina, Washington. Yes, It is being offered in Washington. And where is that being offered? It doesn't say. All it says is Washington location, Seattle research site. I don't know. She'll know about it though for sure.
Okay.
So you can definitely ask her if you're. And I haven't looked at the participation criteria, but somebody else can. It's right there now. Another of our Seattleites has his hand up, so I'm going to go to him, and that's RJ.
Yeah, I'm just pretty much a +1 on. I mean, one of the things, David, is that sounds like your PSA is coming down from 0.9 to what was it,
0.05.
Yeah, to 0.5, and you
0.05.
0.05. Like you're on your way to getting undetectable, and one thing would be to just stay at undetectable PSA for some period of time that would, first of all, give you a little bit of comfort and peace of mind before going on to something else. One of those options, I mean, there's a lot of different options, probably by, potentially, Pluvicto might be an option. Certainly, like chemo with Taxotere would be an option. Like if you, depending on how aggressive you want to get, or, the ADT is no fun. Like maybe you would, say, hey, like I've had the undetectable PSA for a while. I'm ready for a break from the ADT, and then figure out what you want to do. Do you want to do anything else during the break? Or do you just want to take like an actual break from all sort of treatment and then wait for it to come back? It sounds like it will come back fairly soon. Yeah, and then one thing is on the intermittent is that if it comes back, then you can, if you're, what is it, androgen pathway modulation sensitive. So as long as that's the castration sensitive, that I think that's the new more sensitive terminology there, as opposed to the whole castration thing, but is to be able to go forward with that, and then you can come on it, come off it, come on it, come off it, and then you can go back on it if you're not comfortable that if your PSA is higher than 1 or so, then you could go back on it, or you could get a PSMA and then kind of know where the cancer is. But the first thing to do is get to undetectable. And it sounds like you're well on your way there, and then figure out what you want to do along with Dr. Chang.
Right. So I think RJ has just been through triplet therapy, so he's got the T-shirt. I think that we're all saying the same thing. You've never really done a solid period of hormone therapy, and beyond that, every time you've come off, your disease has come back on.
Yeah.
So we need to give that cancer in your body a real good hit, and coming on and off isn't really doing it. And I would say, yes, definitely think about, tell her, I'm willing to do the time. I'm willing to do the time. I want to do 18 months and see how it works. That's one thing. The other thing is have a look at Capitello and see if she thinks, because the Capitello includes Orgovyx and or ADT and abiraterone. So, 2 birds with 1 stone.
Mm-hmm.
So did you click on that link? All you got to do is click on that link I put in the chat, and it'll open and you can look at it later.
Yeah, I got it. I have it in a separate tab for it. I'll look at it later.
Perfect. So David, that's what I would say. I think that's what the AnCan group would say, that you got to do the time at some point. When you've got a nasty situation, which yours unfortunately is, you got to do the time.
I think part of it was my first experience with ADT was a harsh reality for me, and I was looking for any vacation I could get, but and I think she was reading into that let's go soft with the guy, but I'm getting the message that this soft is not going to work.
Look, almost everybody that I know is has your response. They all do. When can I come off of it? What? Have a little chat. Have a little chat offline. Have a cup of coffee, even better. Have a cup of coffee with RJ. Exchange emails with RJ through the chat window. Have a cup of coffee with RJ and ask RJ about the conversation he had with us 2 weeks ago or 4 weeks ago or 3 weeks ago. Everybody wants to come off. Everybody wants to know when they come off. The problem with coming off is if you don't do enough at the beginning, it comes back to you. Some people, it comes back anyway. But if we had a dime for every person, right, Len, who has wanted to come off, and we've convinced them that they need to stick with it, and I would say most of those guys who have stuck with it, they've gotten good results. The guys who have come off earlier, the ones who are dealing with recurrence. It's not always true, but it's from AnCan's experience, it's largely true. Right, Len?
Absolutely, Rick. I agree.
Anyway, David, we got to move on because I've got 11 guys who all want some time tonight.
Rick, we've got Jim Marshall with his hand.
Right here. Oh, okay.
Make it very
Dave,
quick.
Yeah, Dave, how active are you exercise-wise, ADT-wise?
Very active. I'm at the gym or in a hot yoga class every day, or walking and playing golf, 18 holes of golf, walking. I'm pretty active.
All right, we'll talk more.
Okay.
We will talk more about, if you come to the groups, you'll hear a lot of talk about exercise and what have you. But I wouldn't even wait. I would get in. I mean, why wait another 2 months? I mean, right now you're just on the Orgovyx, you're not on the abiraterone. You need to get into 2. I would use the Capitello trial as an excuse to ask for a meeting with her. What you should know, and I meant to tell you this before, there are 3 pretty bad actors in terms of mutations. One of them is P10. The other 2 are RB1 and TP53. And if you have more than one of those, it can be quite serious. So you have one of them, it's pretty manageable, but they're not good actors in the long run. And she should explain that to you, Cheng. But that said, call her up and tell her I want to talk to you about Capitello, and then from there you can segue that into, well, I want to go on abiraterone and I want to do the time because it keeps coming back.
Okay. So abiraterone specifically,
well, I would kind of lean on that abiraterone as a way to talk about the Capitello trial, because the Capitello trial is with abiraterone.
Got it.
But if she says to you, you know what, I can't get you in a trial, or I don't think it's right, because she'll know a lot more about capivasertib than we do. You say, well, maybe we could change. Maybe I could do darolutamide, which is an easier drug. But I would kind of use the abiraterone as a lever to get a conversation with her and Capitello.
Okay.
And RJ's put his email in the chat window, so you and RJ need to, you don't need to, but I would suggest you get together and have a little chat and a coffee, and because we like to see that.
Okay, will do. I just responded with, I'll figure out how to send it to you, RJ. I'll get it to you.
Yeah, it came to me, but you can give it to him. You can give it to him. Just click you did it before to me. Click everyone and find RJ and send him. And if RJ can't find it, I've got it. So you can call me. All right, we're moving along, and I got to get my list. Where's my list of names? Oh boy, here it is. Here it is. All right. All right, I'm doing this pretty much in the order that people entered the room. And I do need to know if anybody has to leave early. Probably can't hear me. Yeah, I'm back. Hold on. Yeah, it's coming back. But stupid internet connection is going in and out.
Maybe you should send me a list of the guys.
Yeah, anybody who's got, I don't need to know if you need to leave early if you didn't ask for time. I only need to know if you need to leave early if you asked for time, so that I don't lose you. Okay, you're hearing me now, right, Len?
Yep.
Yeah, okay. All right, so Tony G in Syracuse, what's on your mind?
Oh, a couple of quick things. I had the bone density scan on March 26th, and the results of that came back in normal range. I have pushed for the Axumin scan. I reminded my oncologist that I had inquired about it 4 times without getting a definitive answer. And so I said, either order the test or tell me why you don't want to order it. And so he has ordered it, but he's also said that he's skeptical about the benefit of it. So,
well, you tell him, this is what I would do. You tell him, Doc, if I don't make PSMA, why shouldn't I get an Axumin scan? What are you going to suggest in its place? That's the question. Tell him, what if I don't make PSMA? The use of that Axumin scan it's not as good as PSMA, but it has a place for people that don't make PSMA, and we don't know if you make PSMA or you don't. Well, because we don't have a test for that.
Yeah, I have had 2 PSMAs. Both with not showing anything, right?
That's right. So, I mean, I love these docs who, well, I'm skeptical. Okay, fine. What do you suggest?
Yeah, he's agreed to order it, so that should be in my near future.
And what was your score on your DEXA scan?
I don't have that in front of me. What I remember is there was a chance of a 10-year chance of fracture was something like 6.4. But yeah, I didn't print it out.
Okay, all right, that's fine. That's fine. That's fine.
I can tell you next time.
Yeah, that's okay. I mean, just make sure that you tell Dr. Guercio that A, the Axumin scan has been ordered, and B, that you got your DEXA scan. So anybody would like to say anything to Tony? And Tony, any other questions?
No. Well, Dave, the group that I'm with here in Syracuse has offered genetic testing. Should I avail myself of that?
Yes.
Okay. Okay.
You've not done any genetic testing. You do definitely need it. So go. So definitely have them do the inherited test. Definitely a very good idea, and then we'll worry about anything else with Dr. Guercio.
Okay. Yeah. I've had two genome decipher tests.
That's different.
That's
That's
different.
different.
Okay. And I did the BRCA screening and came back negative.
Okay, but was that only for BRCA, or was it was it a bigger panel?
No, I think it was just for BRCA.
Okay, then you need to get a wider panel.
Yep. Okay.
Okay.
Yep. That's all I have.
Okay.
Thank you.
Barry B, you've moved from the top of the screen to the bottom of the screen. That's very good. That's very good. What's on your mind?
So I'm in Rochester, Minnesota at Mayo Clinic. An hour ago, I was in a PSMA machine.
Yes.
And of course, I don't have any results because I couldn't read them even if I did. But so I meet with Dr. Heath tomorrow.
Okay.
And, we'll see what that shows. And, but my question was, well, a little bit of good news. My PSA went from 1.3 down to 1.0. And Friday, I got results that it's dropped to 0.065, I think it is. So it started to go down a little bit. And I met with Dr. Hugic at Minnesota Oncology. And he's flexible. I told him about the ADT is just raising hell with my sleep. And so he said, he's amenable to maybe modifying the ADT drugs to pick, something different than Lupron and Abby to help with that.
Mm-hmm.
But I told him I wanted to stay on it for a year, like you've always recommended, and do my time. And Dr. Heath wants me to do that as well.
Mm-hmm.
But he and Rick, I know you mentioned this before. He brought up to me that I'm kind of agreeing with what you said, that maybe I should look into doing some debulking treatment.
Right.
And but I read up on debulking, both surgical and radiation wise, and both of them sounded or read a little nasty. So is that something I should be worried about, or is it pretty standard procedure now?
Well, the first thing I say to you is, and certainly at your age, and others may disagree, and if they do, they should pipe up, but I absolutely wouldn't consider surgery.
Okay. Yeah.
So if you're going to debulk, do it with radiation.
Okay.
The second thing is, it's controversial. The stuff come out recently that says it's good, you should do it. And there's other stuff. I think MD Anderson said it's not worth doing, and Kishan said it is worth doing. The MD Anderson was Anna Aparicio. I've got to write this up for you guys. I haven't had a chance to do it yet. If it were me, and we've seen it with a lot of guys, I definitely debulk, and I do it to the prostate, maybe, but it's definitely not always the case. Maybe I talk about across the pelvic girdle, but definitely to the prostate gland. That would be my approach. So I would discuss it with Dr. Elizabeth. She won't do this to you, but others might at Mayo. Don't fall for the Mayo, we got to do surgery line. Okay? Oh, yeah. Because they were the originators of debulking with surgery, and they've done trials on it, and the side effects are just too great. So, I would say forget about it, but I would consider it. I'd also suggest, oh, Dr. Paul's gonna like this one. I'd also suggest, and Steve yes, is in, yeah. Can we mute, please, David? Thank you. I'd also suggest maybe low dose E2 to estradiol, low dose estradiol, which is what Steve did in Seattle to deal with the sleep issues and the HT side effects, and see if she'd be willing to discuss it with you. I'm not saying going off the ADT. Which ADT? Which ADT drug are you on?
Lupron and
Lupron.
Abby.
Yeah. So I'm not saying going off of the Lupron and staying with the Abby, but adding to the Lupron a low dose patch. Dr. Paul, what would you, in your opinion, think that patch should be in terms of dosage?
Well, again, we term it as add back estrogen, which is just adding back what your body has been used to up until you started Lupron. And it's a bit of a variable. It's personalized, and you're using it to alleviate symptoms. So you might start with one patch twice a week, Tuesday, Friday. And if you feel much better and the symptoms are better, stick with it. You may need 2 patches on Tuesday and 1 on Friday. So, I mean, you're titrating not to control your cancer, so you don't have to get upset or worried about are you impacting on your cancer treatment. You're titrating to feel better. And that's a good way to start. And of course, I've got to throw in, because Rick, I'd have to. If you added a couple of more patches, you could dispense with Lupron, because we know that it's equally effective, but that will take time and that will take a lot of reprogramming. But certainly for your comfort and quality of life, a little bit of estrogen goes a long way.
Yes. Thank you. Look, you're
Thanks,
smiling. Larry's smiling. All of our estrogen guys are happy now. We've given you the promo. And guys, I promise I will get to the patch trial and write it up, or somebody will. If it isn't me, we'll give you more information on the patch trial in due course. But there was just too much for this week, and most of you heard about it anyway. So, Barry, I think those are our words of advice for you. I just wanted to say to David D that yes, we do often recommend acupuncture. We also have had a lot of good success with the Ember watch that probably Jeff Markey is wearing right now. That works real well. Yep, he's showing it to you there. There's a lot of good stuff, but I have to take care of my Emperor of Estradiol here. So I thought this time I'd suggest a low dose patch. So there you go. I'm smiling. You can't see me because I can't even get in with a camera now, but it's okay. I don't need
guys.
All right, we're going to keep moving. Anything else, Barry, or can we keep moving?
All good.
Okay. Dr. Pierre, you are up next.
Okay, I just wanted to give an update. Last time I presented, I'd had my prostatectomy in mid-December, and I was in a holding pattern because my PSA was still coming down. recommendation from Mayo, Dr. Kwon, was that I not do anything until the PSA either plateaued or started coming up, which it has, as expected. The plateau was 1.73 on January 16th, and the following PSA on February 7th was 1.78. Then it on March 2nd, it went up to 2.8, March 23rd, 3.8, and March 27th, 4.33. So the recommendation right now, well, I got a PET scan and an MRI on 3/28 or 3/27, I guess, at the Mayo. And the PET scan shows nothing in the prostate bed, but some lymph nodes in the right iliac and right retroperitoneum. And I also have a couple ribs that had barely, showing spots, basically. So I may have two Mets in the right fourth and sixth rib, and then some retroperitoneal and pelvic nodes. Recommendation at that time was triplet therapy, which I haven't decided on yet. So I did start abiraterone and Orgovyx on 3/28, and I'm doing a teleconference with Dr. Ryan Phillips at the Mayo on the 9th, so this coming Thursday.
What sort of doctor is he?
He's a radiation oncologist.
So let's just back up a little bit here. Did the PSMA scan show anything?
Yeah, it showed the lymph nodes and the two ribs.
That's what the PSMA scan showed. That wasn't the C11. That was the PSMA, right?
Correct.
Okay. And I'm curious, did the C11 confirm that or not?
He didn't do a C11. He did an MRI and PSMA.
Okay, perfect. Okay.
Yeah, they don't usually. He told me they don't do the choline unless somebody's PSMA negative or whatever.
Yeah, well, he switched on that because he always did the C11 and we could never get him to do a PSMA. So
yeah, they've switched. They're doing pretty much 100% PSMAs now.
Okay, that's good. And who is suggesting the triplet therapy?
Kwon's the one that suggested triplet therapy. And if I elect not to go for it, then his next recommendation was doublet plus radiation.
Okay. So I'm going to give
you meeting with the radiation oncologist.
Okay. That's not who you need to meet with. And I'm going to give you the same Kwon speech I give time and time again here, and I get slammed for. But Dr. Kwon is not a genitourinary medical oncologist. He is a urologist. He's a urological oncologist.
Mm-hmm.
He's out of date. He doesn't treat in the most common way until his arm gets twisted, like now when he's finally dropped C11. But I can't tell you how many times we've asked him for a PSMA scan. He overtreats. We've seen him do that many, many times. The radiation oncologist, and I say, David Opp is here. I'm sorry, David, but we've seen it so many times, and he's killed people. This is what bothers me. We can give you names of people he's killed because he wasn't up to date. Now you can go, just like David does. You can go to Dr. Kwon. He'll keep you alive until the way he treats doesn't work anymore. But it's very hard for us to support people who see Dr. Kwon because we don't agree with what he does. Go and see a GU medical oncologist. If you want to keep going to Kwon, Dr. Heath is there. hands down, a terrific, good. She's conservative. She's not going to go for some of these treatments that you hear here with monotherapy and what have you, but she's really good. But Dr. Kwon is not, Dr. Kwon, in our view, Dr. Kwon should not be treating men with advanced prostate cancer. He should give it up after they've had surgery. So, you know, I would say if Dr. Heath says, yes, you need triplet, let's do it. It doesn't sound to me like you have enough mets to warrant triplet, that you're really borderline. Maybe you've got 4 spots. We don't really know.
Yeah, well, yeah, I think I counted 7 positive nodes. And one of the questions I had, you know, when he mentioned triplet was Pluvicto. And he said no, for whatever reason. As I read about it and looked at my scan, my SUVs, you know, were pretty low on the PSMA. And I guess Pluvicto does better with high SUVs.
Well, you know, it's too early for Pluvicto, way too early. You need to keep that in your back pocket. You maybe don't have to do the chemotherapy, but it's way too early. You're barely out of treatment. You haven't really done any hormone therapy yet. You could respond to hormone therapy. Right. But you need to go see a genitourinary medical oncologist. We can suggest somebody for you in Boston. We can suggest somebody for you at Rochester. We can suggest somebody for you in Minneapolis. I mean, you're schlepping all the way from upstate New York to Rochester. I mean, it's crazy. I mean, why not go down to Memorial Sloan Kettering? Go to Dana-Farber. Go. You know, we've got so many guys who are really good. Go to Chicago. You want a doctor who's going to work with you and treat you with the least invasive, but be very, very good. Go to see Shmulewitz in Chicago. We know he does that. We've seen him do it. Yeah.
I did see a medical oncologist at Roswell Park in Buffalo, and he was amenable to the doublet therapy, plus or minus radiation.
Roswell doesn't have a good department. They don't have great GU med oncs. We've been dealing with this for years. My dear board member and friend, Professor Bill, who passed away several years ago and was a yeast geneticist at Roswell Park, was treated there. We saw it then. It hasn't changed since then. We moved him from Roswell Park to Dana-Farber, to Dr. Chowdhury, because he wasn't getting the right treatment. I mean, you can navigate yourself, but if you come in here and tell us and we don't agree, we're going to tell you. And for your own sake, we just want you to see somebody who's really solid and give you good advice.
Okay. One of the recommendations was if I was going to go for a triplet, that I see Dr. Hubeck in Minneapolis. Is he?
Why? What's wrong with Dr. Heath? What's wrong with Dr. Heath? You know, Dr. Heath is the chief medical oncologist at Mayo. She's the chief medical oncologist at Mayo. I don't know what goes on with Kwon. I don't know why he refuses to refer within his own institution, but it makes me really suspicious. RJ, what do you have to say?
Yeah, I mean, I would second that. Well, it sounds like you already talked to one medical oncologist that said doublet therapy, right? Get on ADT plus a ARPI or an ARSI as kind of like that's the baseline. And I would say I did both the spot radiation and the chemo, but it's not a either or. And I would say that the chemo is no walk in the park, but the SBRT, like especially like for the lymph nodes and the ribs are a little bit harder, but like you don't feel anything from that, and like there's no side effects from that. Like that's a much easier thing to do along with a doublet before you start thinking about escalating all the way. Like the triplet therapy is quite a escalation, so that's something to think about too.
How many mets did you have, RJ?
I ended up with I think
Before
it's six or
before-
seven.
6 or 7, and they were bone, weren't they?
Yes.
Right.
Well, 5 of them were
5
bone.
of them were bone. I mean, if you got 6 or 7 and 5 of them are bone, it's a valid conversation.
Yeah, I got 2 in the bone and 7 nodes, basically.
Well, you've got 2 in the ribs, and are they sure? Because the ribs are very difficult to be certain about.
One of them, they're pretty sure, even though the SUVs on all of this was pretty low, but you know, there's nothing over 4.
Yeah,
but,
I mean, so there you go. Barry, you've been around this mulberry bush a couple of times, right?
Yeah, Pierre, you really like Dr. Heath. And she understands the different, the silos that they have at Mayo, but she's just wonderful. She's knowledgeable. She tells you why she's recommending something. She listens to what you the symptoms you're having and issues you have and thoughts that you have. And then she comes back and gives you, a couple different alternatives to look at. But she'll tell you, this is what I would suggest that you do. And, they spent a buku amount of dollars to get her out of Michigan, and there was a reason for it. And I'd highly recommend, setting up an appointment next time you're coming back to Mayo to meet with her. And, if they give you any grief or something, I'm seeing her tomorrow. So if you want to meet with her, I'll tell her that a guy named Pierre wants to see her.
Okay. Do you know how far out she's booking?
Dr. Pierre, we'll take care of that when she's booking. If it's too far out for you, we'll write to her. Barry,
Okay.
but we're not going to get into that. But what I would say is, from where you live, it's just as close for you to go to Boston. Go see Atish Chowdhury in Boston. He is so committed to undertreating. He's got a big study on there around side effects of hormone therapy. I mean, he's great. Or because I think Boston's closer to you than Chicago, right?
Yeah, it is. I can get a direct flight to Boston, whereas I can't to, I can get a direct flight to Boston or Chicago.
Okay, well, I mean, or go see Dr. Shmulewitz, who is great in Chicago. I mean, those guys are easy. They're going to treat you with the right amount of treatment, and I'm not going to be concerned about treatment on their watch. I'm not going to be concerned about treatment on Dr. Heath's watch, but again, you don't need to go
easier to get easier to get to Chicago than Minnesota for sure.
So
can you put those names in the chat?
Yeah, I
Thank
will
you.
try. If not, I'll send them to you. Okay.
All right, thank you.
Because when I'm moderating, it's a little harder. But if not, I'll send them to you later tonight or tomorrow with the references. Len, you thank goodness you got your hand up. I can maybe find these names quickly.
Okay, I'll stall for you, Rick. Pierre, do you know what the SUV was for your liver, spleen, or kidneys, ureters, anything like that? Was it
the liver lit up really high. Let me see if they even mention the SUV. But when I looked at the images, I mean, the liver and salivary glands were pretty hot.
What was it?
And the nodes weren't as impressive as the stuff that normally picks up
Well,
PSMA.
give me a number though. Give me an SUV.
I don't know if they mentioned it for liver. Let's see.
Because the point I'm trying to get to here is if all of your so-called lesions are SUV 4 and lower, I think there are oncologists who would say it doesn't even need to be treated. And with PSMA PET scans, positive uptake in the ribs is notoriously false uptake due to stress fractures and in the ribs. You're not a young man. It happens. It happens to all of us. So it doesn't sound to me like triple therapy is warranted, given the low intensity, the low SUV values that you're showing. And as I said, some of those rib lesions may not be real.
Yeah.
The
report doesn't give me the SUV of the liver.
Okay. Yeah, I was just trying to get at the background physiologic uptake. But in any case, 4 and lower is very low.
Yeah. Now, the question in my mind on a low PSMA is, I mean, my tumor potentially has de-differentiated, because I was a 5+4 with cribriform and intraductal. As the tumor de-differentiates, does it produce less PSMA? Just like some tumors won't produce PSA?
Yeah, it could. It could, certainly. It can produce less PSA, less PSMA.
Yeah, I think that's why, that's why they want to be aggressive. When I saw the oncologist at Roswell Park, his first, recommendation was doublet, but he was willing to consider, adding docetaxel also. But only if the insurance authorized it, obviously. He's part of the, I'm trying to remember the name of the study that's using another RP, it's the Aspire study. So he's doing docetaxel with apalutamide and I think ADT, which he mentioned, but I don't want to be part of a study right now because in my mind, quality is as important as quantity. What I don't want is irreversible side effects like neuropathy or, if ever I go on Pluvicto dry mouth.
The study's not going to bring those on, Dr. Pierre. It's the treatment. And any of these drugs, together with docetaxel, can be prescribed to you right now, any of them. So you don't need a study. You don't need to be in a study. If you're with the right doctor, like a Dr. Schmulowitz, he's going to give you what he thinks is right.
Okay.
And he's going to go fight for you with your insurance company, but they're all approved. But we've got, I'm afraid we've got to move on because we've
thank you for your time.
And I put Dr. Schmulowitz's.
Yep, I see it.
And I also put Dr. Chowdhury in there for you too.
Thank you.
Okay, and they know us well, but please cover your ass. And or Dr. Heath, who you know, and Barry will tell you more about Dr. Heath, and we like it just as much as those two. But those two you don't have to schlep so far.
Okay, thank you.
Jerry Pelfrey.
Yes, sir. Real quick. I have been off Orgovyx now for 3 months. And my last PSA simply went from 0.01 to 0.02. But the the interesting thing is my testosterone hasn't changed a bit, but I don't think over 3 months I would see much of a testosterone change. I'm still taking Nubeqa. So really, I guess the question would be for Len, because I know he's on Nubeqa. What should I expect for testosterone? At my age, I really don't expect it to go up very much at all, really.
But you're also on Orgovix, right?
No, I'm off it.
Oh, so you're on monotherapy with darolutamide, Nubeqa.
Right.
For how long? For how long?
3 months.
Oh. Well, typically it will rise. Now, that depends on a lot of factors, your age, how long you've been on ADT. So it's hard to predict if your T levels will recover, and if they do, how much. We just don't know.
All right.
What is your T level now?
12.
And how old are you, Jerry?
80.
Well,
and I've been on ADT since, well, really for almost 7 years.
Well, I mean, Jim Marshall is a perfect model for you. Jim's T levels never really recovered, although for a while, when he had the decimal point in the wrong place, it looked like he had 300.
Hey, I made a mathematical error. That's all.
That's all.
Wait.
Misplaced decimal point. So, Jerry, I wouldn't have too high hopes that the T levels will come up. On the other hand, maybe that'll give you some comfort that with the T levels really low, the chance of your cancer recurring is also probably low.
Yeah.
So.
Yeah, I know. Then the other quick thing is I used to have a GU med-onc called Dr. E, but now that she moved to Oregon, it's rather interesting that OHSU, I guess, doesn't do any video. So luckily I have my med-onc here in Tucson, and he's been with me since 2019 through my first episodes with Mayo and Dr. Singh, and then the last couple of years with Dr. E. So I'm kind of at a situation where I really don't want to go through trying to find another GU med-onc at this stage of the game. Any thoughts?
Yeah. I mean, first of all, OHSU doesn't do it because they cannot do it. They're not allowed to do it because of the licensing laws, and the practitioners, the nurses and the nurse practitioners, they can't be treating people out of state. That's what's going on there. It's not because they don't want to do it. Same thing with Dr. E. I'm sure she'd love to do it. I mean, my thought is you were willing to fly to Houston. Why don't you fly to Oregon?
Well, I can, but but they haven't come back to me with anything yet.
Have you asked them for an appointment with Dr. E? She may not have a licensing through yet. I don't know, but I think she does. Have you asked them for an appointment, Jerry?
No, not directly.
Ask them for here's my suggestion. You stay with the doc you've got. You were willing to go to Houston, so you can, instead of going to Houston, you can go to Portland, and you stay where you are, and you're comfortable with her. Anyone else want to chime in on this one?
Is there anyone else going to Dr. E? I mean, there were other people going with Dr. E when she was in Houston.
I don't think she's had, I think she's still in this transition. I don't know whether she's taking appointments, but when she takes appointments, there will be people. I mean, rather
Okay.
than judging Dr. E,
I'm not judging Dr. E. I'm really judging OHSU. And I understand.
Well, that's the same thing. That's the same thing, Jerry. She is OHSU now, and she's chief of the group. So they can't do anything about it. I've spoken to her about it. She's frustrated.
No, I know she is.
These nurses are not licensed to work with people who are being seen virtually outside of the state of Oregon.
I understand that.
Okay, then I could suggest to you docs in California, but they won't give you video appointments because they can't do it either. You know, we're spoiled. There was a freedom on video appointments. A lot of people got them, especially during COVID, but now they're clamping down. It's not as easy. So the alternatives now, go see Alan. You want somebody close who's really good? Alan Bryce at City of Hope in Phoenix. Really good.
Wasn't he head of Mayo in Phoenix?
Yes, and he's now working out of City of Phoenix in Glendale.
Right. That happened about a year or two ago.
It doesn't matter. We've got to move on.
Yes, move on. Thank
okay,
you.
Alan Bryce, you want me to put his details in the chat for you? Hold on a minute.
While Rick's doing that, Jerry, I wanted to say your rise in PSA from 0.01 to 0.02 is meaningless. Just forget about it.
Oh, I know.
Oh,
I know. I have. Yeah.
Okay.
Yep.
Hey, my testosterone matches your experience, Jerry. I was on ADT for 7 years. I'm 78. At 77, I dropped off Argivix. I'd only been on it for about a year. At 3 months, I was 11. By 8 months, I was 49. It was still going up about 25% a month. So it's not real fast, but it kept going up. And I had to stop because my oncologist thought it was too high. But I just wanted to let you know I had exact same thing as you. 11 after 3 months, it hit 11, and it just kept rising. So you might find I know mine in about a year and a half would have been well over 150 at the rate it was rising. Just something to think about.
Well,
gotta move on, guys. We've
All
got
right.
11 people today. Gotta move on. Work with me, please.
Thanks, Jeff.
Joe Siri, you wrote to me and you wanted to update us on on how you're doing on your hormone therapy.
But very quickly, what I wrote was, for some reason, my testosterone went from 159 to 4, and the PSA went from 0.2 down to 0.2 to 0.1.
So those are exactly what's supposed to. That's exactly what's supposed to happen. And when you say for some reason, well, the reason is those meds that you're taking. That's exactly what they are designed to do.
Even in 2 weeks?
Some people respond real quick.
Okay.
You're on Orgovyx, and Orgovyx works right off the bat.
No, I'm sorry. I'm on Lupron and Zytiga.
Julian, man, I asked, please, I feel so bad when people say, oh, I've got to leave. I asked everybody up front, let me know if you got to leave early. I'll come to you next. Hang in there. Sorry, Joe, you're on Orgovyx and Zytiga, right?
No, Lupron.
Oh, you're on
Which-
Lupron and Zytiga.
Lupron and
And
Zytiga.
when did you get that first Lupron shot?
March 3. And we,
I don't know. I have to defer. I have to defer to Dr. Paul, because this is a tricky one. I was thinking you were on Orgovyx, but if you and your testosterone has gone from what to what?
159 down to 4.
Dr. Paul, help me.
That could be Zytiga. I think Dr. Paul left.
Oh, did he?
But anyway, Zytiga could bring his T levels down very fast.
Okay. So your PSA is less than 1.
It's 0.1 down from 0.2 down from 0.3.
Okay, so let me just put 426. So PSA is 0.1.
Yes.
And your T is 4 from 159. Yeah, I'll stand by Len, and I don't know if Zytiga can work that well, but I trust Len if he thinks it can. But this is what the meds are supposed to do.
Right.
So don't be surprised that your testosterone is going down and that your PSA is going down. That's why you're taking these meds.
Right.
Anybody want to comment? Anybody else have that experience? Sir, we've got a hand up. Whose hand do we have up? Hold on a minute. Dennis.
Real quick, I'm going to go through some good stuff. This is my 10-year anniversary.
Hold on, Dennis. You had your hand up. Did you want to talk about Joe
Oh,
Siri?
no, that was from the last one. That was from Jerry. I was going to mention some things about Jerry.
Okay, sorry. All right, so I'll get to you. Anybody? RJ, did you want to talk to Joe Siri about?
Sure. I would just say mine came down quite quickly with same combination, right? The Lupron and Zytiga. And yeah, like what Rick was saying, that's what it's supposed to do. It's a good thing when it happens fast. It's a good thing.
Yeah.
Thanks.
Yeah, I mean, Joe, be happy.
Oh, I was thrilled, and Barbara loves all of you. So
okay, well, tell Barbara that people who respond quickly, it's a good sign. They tend to have the best results. There are studies on this, but if you come down quickly and you respond quickly, then you tend to have really good results. Dr. Russ, do you know anything about this quick response on hormone therapy when we're still working with an agonist?
I don't, but I think it's, you said it before, it's a good thing. Is that what the drug is supposed to do? And I'm sure everybody responds differently to that. So I'm not sure why we're discussing this at such length. It's a good thing, I think.
That's right. Okay. I take the hint, and I'm going to move on to Julian because I don't want him to go without him telling us what's on his mind. Are you still with us, Julian? No.
Where is he?
Okay. He will. All right. And no, Julian, he had to go. Dennis, now's your turn.
Okay, I just start from the beginning. This is my 10-year anniversary this month from de novo metastatic and Gleason 9, 7 bone mets to start out with. And right now I'm doing well. Just had a 3-month drug holiday from the Eligard. Still on the darolutamide Nubeqa. PSA is about the same, went from 0.06 to 0.04. Could be real, who knows? Testosterone less than 12. It's been, this is my 3rd break that I've taken, drug break. This one's a little different, but the testosterone has always been less than 12. So kind of similar to what Jerry is seeing there. I also had a DEXA scan done and got from the Prolia, I have a great improvement in the density in my lumbar spine and my left femur, where some of my largest mets were. I have also started Crestor statin because my cholesterol, I guess some of the thinking about the good cholesterol previously being so high, it would overcome the bad cholesterol. But now they've changed their opinion about that. And the risk for first-time heart attack has risen significantly because of that. So with the Crestor, I started around mid-March. My cholesterol total now is 121, way down from way over 200. LDL down to 25 and HDL 78. So everything's where it needs to be. With that, triglycerides also went from 133 to 89. That's with a 10 milligram Crestor. Unfortunately, my back pain continues. I've been trying lots of stuff. I tried pregabalin, which is a nerve drug, and had to quit. I had vision problems and stability problems and all sorts of issues. Stopped that. So back to taking a leave.
What drug was that? What drug was that, Dennis?
Pregabalin. It's sort of like a gabapentin, but not quite as strong. But it didn't do well for me. It didn't relieve my lumbar back pain, and it caused me to have other problems. My vision was just like I had been to. I go to my eye doctor regularly for checkups and stuff. And when you get dilated for them to look at the retina,
what's your PSA right now?
PSA is 0.04.
0.04. So, and you're still on the Nubeqa monotherapy, right?
Yes.
And how are you doing with that?
Very good. I love it. It's so much better than the other IDs that I've tried before. It's the brain, no more brain fog, very little hot flashes. And when I do get them, they're not severe at all. So I would highly recommend Nubeqa.
Yeah.
And it's not causing me any problems, so I'm just going to keep taking that. But the Eligard was giving me issues, so I stopped that. Feel better from not taking the Eligard, and everything seems to be holding steady. Testosterone is still less than 12, and the PSA is dropped a little bit, actually.
Any questions for the guys here right now?
Well, yes, the issues are today, after coming back from my blood draw, that gave me all good results, had a bowel movement, and the toilet bowl had a lot of blood in it. So I'm wondering if it could have been from proctitis that occurs some years sometimes after you've had radiation. The only radiation I had was the debulking.
And how long ago was that?
About 5 years.
So, I mean, I'm 17 years out, probably 16 or 15 or 16, no, 16 from radiation, and I still get blood. So if it's there, have you ever had it before?
No.
I don't know. Len, you got your hand up, thank goodness.
Yeah, it's possible, Dennis, that it could be radiation proctitis even 5 years later. You probably should get a colonoscopy. Dear M, could you mute? So yeah, it could be the radiation proctitis. You should get a colonoscopy. And the other thing I wanted to mention is that darolutamide has fewer drug interactions than any of the other drugs in its class. However, it does have an interaction with Crestor, and it will elevate Crestor levels as much as 5-fold in your bloodstream. So you might talk to your doctor about either using a lower dose of rosuvastatin, Crestor, or taking it every other day, because I've heard that there is some risk to having your LDL go too low, believe it or not. And yours is already very low. Anyway, talk to your doctor about that.
Yeah. Okay. 5-fold, you said, effect?
5-fold increase in the level of
Crestor
in your blood. Yeah.
Huh. Okay.
Yeah, great pickup, Len.
Yeah.
Yeah.
Yeah. The other issue is Aleve that I've been taking for the back pain, and I think maybe, but I'm still below. I don't take more than 2 of those in 24 hours. And I've also started taking, my GP gave me something to take to reduce the adverse effects of the Aleve. I can't remember the name of it right off the top of my head.
Well, I think what you've got to do is make sure that your PCP is checking all of your drugs and prescribing stuff that works with the other drugs you're taking. Because yes, this Crestor one, I missed it, but the Crestor one is pretty well known. Jay Mills, you have a comment, and then Dr. Alfredo.
I was just wanting to ask Lynn, this may be an opportunity for him to go to the PCSK9 inhibitors that are so difficult to get away from the statins to get onto those that have the lower side effects profiles. Would that be
above my pay grade? I honestly don't. I mean, I know that there are other anti-statin drugs, but I just don't know. But other people may want to comment on that. Alfredo, do you have a comment?
I think Alfredo knows about this.
I have 2 comments. One is the PCSK9 drugs work great for some people. That's a cardiologist conversation. And Dennis, what I wanted to ask you specifically was, when was your last colonoscopy?
Probably over 10 years ago.
I would move that to the top of the list. I mean, sure, talk to the cardiologist about the new drugs, but you're due for a colonoscopy, my friend.
Yep.
Notwithstanding everything we've just discussed, all of those things are still possible, but you want to rule out the things that a colonoscopy would reveal right away.
Yeah. Does age have anything to do with it at 80 years old?
Well, there's debate about at what age do you stop doing colonoscopies.
Yeah, last time I saw
the right answer depends on all kinds of things. Is there colon cancer or other GI cancers in your family, even remote relatives? So it's a debate. And I would just say that although for many people the colonoscopy is unpleasant, it's actually not that unpleasant once it's over with. And it's probably worth getting. That's just my
Yeah, the last time I talked to my gastroenterologist was probably about 2 years ago, and I think the issue of age came up, and he said, "Well, we probably don't want to do it." So
Yeah, but that was before you had the blood.
yeah.
So I think he'll say, "Oh yeah, good. Let's go do it." I think. Let me know if he says no.
Okay. Thank you.
Well, of course, they'll also be able to tell you if you have radiation proctitis if they do the colonoscopy, even if you don't have colon cancer.
Right.
Okay.
Yeah.
So it's worth doing.
That's
Yeah,
right.
it's very visible.
That's right.
Sounds good.
Okay.
One last thing. I not directly related to prostate cancer, but just my own personal stuff here at home. My wife was just recently diagnosed with Alzheimer's disease, and so I'm spending a lot of time away from my my prostate cancer stuff to bone up and help her out, help both of us out through this process here, this journey they're about to start.
Yeah, I'm sorry to.
So
I'm sorry to hear that about Mary Lou.
yeah, it was. She'd previously been tested for cognitive decline, and it moved from a mild to a moderate up to a severe short-term memory stuff. And then we also were able to get the new blood test that's just recently approved by FDA, where they do a amyloid plaque ratio. And
I'd love to talk to you about it, but we still got 4 guys, Dennis. And
okay, all right. Thank you.
What I do want to say to everybody who's still listening is that we do have a new, and it's been in the reminder, but we have a new group, email group only at this point for men who have any heart issues. And we'd invite you to sign up right now. Okay. I'm just muting you, Alfredo. It's just an email distribution. Dr. John is running the group. He is terrific. He's sending people out definitions, and he's giving people, telling them all about what everybody's situation is. And we've done this with inherited mutations. And now, if it works out, we will turn it into a group either once a month or once a quarter. But if any of you have heart issues, heart considerations, please sign on to this group. And you can do that by letting me know or Dr. John know, and we'll add you to the distribution. So it's specifically for men with prostate cancer, any level of prostate cancer that also have heart issues, okay? All right. I'm not sure why, but all cameras are currently being used. Okay, you don't need to see my face. It's perfect. The next person on the list is Richard Fisk. I hope he's still here.
I am still here.
Oh, great. Okay, that's why I was looking for your face, but I couldn't see. Now I can see your face.
Yep.
Mr. Fisk, we haven't seen you for ages. What's going on?
Well, I'm in what I believe is termed a durable remission. My PSA as of January was 0.014. I'm now 15 months having beyond completing 24 months of ADT. The issue is ongoing fatigue and weakness. I've got the same level of fatigue and weakness that I have that I had when I was on the ADT. I'm exercising regularly. Diet's good. I'm seeing an endocrinologist, and he just did some blood work. Testosterone, total testosterone right now is 169, and he also found LH and FSH are both very high, which apparently means that my adrenal gland is hammering the testes and they're not responding. So my question is, well, like I say, I'm exercising about 4 days a week with pretty intensive exercise. Question is, what can I do?
Oh, it's a tough one. 169 is decent, but it's not great.
It was up to 250 last June, and it's dropped.
Oh, okay. So yeah, I see T equals 295 in July. So it's dropped. Could just be age. Dr. Alfredo, help me out. Help us out.
I don't know how helpful this will be because it's really anecdotal. But my number one problem these days for many months now is fatigue. And I saw a primary care physician recently who said, let's try. I mean, one choice, of course, is the drug they give to
Ritalin.
Yeah, one choice is Ritalin. Ritalin made my blood pressure go up. So the PCP said, there's an interesting side effect of, man, my brain is locked up today, of, Len, what's the common Wellbutrin, sorry. Said, let's take Wellbutrin, which for some people, it's an antidepressant. It's usually prescribed for depression, but for some people, it gives them an energy boost. And I have to say, I've been taking it now for a few months, and it's subtle, but I think she's right. So I'm not going to stop taking it. I'm taking the lowest dose, but it's one of these paradoxical things about neurochemistry, just like the Ritalin story. This is the Wellbutrin story. Oddly, it helps many people with fatigue. So I just throw it out there. Don't take it. Don't get it prescribed by me. Get it prescribed by somebody who's actually one of your treating doctors. But ask about it.
I actually had taken it in 06 and 07 for depression, and seeing a shrink now, and he prescribed Wellbutrin, which I did not take because of the it didn't find it helpful in 06 and 07, but based on what you're saying, it may be worth revisiting.
And I would specifically ask the shrink if he knows this anecdotal story about it helps people with fatigue. He might say he's never heard of it, or he might say, yeah, that's worth a try. But I'm taking the lowest possible dose, so I'm certain I'm not harming myself. And it seems to be helping.
Okay, thank you. I talked to Dr. Paller about testosterone supplements, and she at first said no, and then said no until 2 years out from ADT. So we'll see where that goes.
So, and you're 15 months out right now, correct?
Right.
Now, the other thing that we mentioned in passing right at the beginning that some of the guys have had good luck with is Ritalin. So, you can talk about that with certainly with the shrink, with the psychiatrist, and with Dr. Paller, or and then John McPhee has his hand up.
Yeah, you mentioned you were going to the gym 4 days a week. None of us are 20. Make sure you leave enough time between workouts for your body to recover.
Good point.
Oh, I understand. I'm actually have an elliptical at home that I alternate days with going to the gym. I recognize that every other day is good timing.
Great. I mean that's also a good suggestion by John McPhee. Allow yourself to recover and go easy on yourself. But it's tough when they take all your testosterone out of your body when you're already in your 70s, and it just doesn't come back the way it does if you're in your 50s or your 60s. It's just tough. Len, what are you thinking?
Yeah. Well, one question is for Alfredo. What was your fatigue low T level related or something different?
Not low T related. It just started after my radiation, and it has kind of continued. And I don't want to say my fatigue has completely gone away. If I compare my fatigue level nowadays to my pre-prostate cancer life, it's an order of magnitude different. So my overall productivity is low. I'm tired almost every afternoon, but I think I'm a little better now with the Wellbutrin.
Okay. Thank you, Alfredo. Appreciate it.
And Richard, I think you and I spoke about this on the phone, but I had the same experience where after being completely on drug holiday for the past 15 months, in my cases, I think it's the same for you, you just said, right?
Yes.
My T level, nevertheless, has been drifting down from about 300 to like my latest one was below 150. So that's
exactly what I'm saying.
That's what you're going through, right?
Yes.
Yeah. Something going on there. I don't know what it is.
Welcome to the club. Welcome to the club.
I've only fought my way to this endocrinologist, and I've gotten the blood tests. I haven't seen him yet, but I wanted to be ready when I finally get to him again.
Yeah.
No, thank you, Len.
Sure.
That's all, Rick. Thank you.
Thank you. So I just want to make sure, David Opp, are you still here or have you dropped yet? Shout up if you're here. So we have lost two folks, David and Julian, who we will definitely promote next week if they're with us. And just to give you an update, because it's right at 7, it's right at the top of the hour. We still have left Gary Martin and Dan M. And that's it. So we're doing pretty good getting through everybody. So bear with us, hang in, don't leave these guys hanging. The next person is Gary M.
Yeah, quick update. Finished radiation therapy at Mayo a couple of weeks ago. Debulking to the prostate, IMRT, and pelvic nodes, I guess salvage radiation, 26 fractions, and SBRT, the MDT to bone spots. There were 3 fractions of that done. Did have some significant side effects, fatigue, nausea, indigestion. The major side effect was at 24th fraction, I got more constriction with urinary function, and they had me start the self-catheterization. My question is if any of you folks had similar experience, and have you recovered your urinary function? I was playing around with the doctor's advice with the Flomax up to 3 capsules. I was getting some dizziness from the low blood pressure side effect, and then tried some silodosin. That's another similar drug to Flomax, but it didn't seem to be effective. So has anybody had a similar experience with radiation therapy?
Are you still catheterizing?
Yes.
Okay. So, anybody here who's had to catheterize as a result of salvage radiation?
Yeah, it's inflammation of the prostate.
And inflammation. Okay. So yes, this is, this is debulking in a situation where Gary's already gone through triplet, and they are debulking. Unfortunately, Dr. Paul has left, and he would be a good person to address this. And I don't know, anyone else got anything they'd like to suggest, think about, ideas? Dr. Russell, thank you.
Well, I didn't experience that, but I would guess that this would be transient, related to the inflammatory reaction, edema from the irradiation. So I would, again, I can't speak from any experience because I didn't have that kind of treatment, but I would think this would be limited, but it's something you just have to wait and see.
Yeah. Okay. That's what the physician is saying.
Can I ask anybody in here, especially Dr. Russell, but anybody else, is prednisone appropriate, low dose prednisone appropriate to reduce the swelling in a situation like this?
Yeah, actually, they did have me do that, a taper dosing for 5 or 6 days of, that was about a week ago.
Well, maybe call them and ask them whether you should stop that altogether.
Okay.
Because if you still find it, and you still need to, this is a bit redundant, but you still need to catheterize, I assume, that you still can't pee.
Yes.
So, I mean, I do a couple of things. The first thing is I would, and this was done at Mayo in Rochester.
Yes, Dr. Brian Davis.
Well, I would call Davis and ask him, and then I would ask him to put you in touch with one of the urologists, not an oncological urologist, but just a benign urologist, and see what other ideas he might have. Because although I'm sure that Dr. Davis addresses this all the time, I mean, they are very aggressive at Mayo. They are.
Right.
We see this at Mayo. Because they are on the aggressive side in Rochester. That is, I don't want to say the same thing is true in Phoenix or in Jacksonville, but we see it. And I think at this time, if you've still got problems, then I would start with there, or maybe he say go see a local urologist and start working. Do you have a local urologist, Gary?
Yes, I do.
Have you talked to him?
Yeah, he's the one that prescribed the psilocybin, but it didn't improve the situation, although it was supposedly more effective at the urinary function and had a lesser effect on blood pressure than Flomax. But I've switched back to Flomax, taken a couple of capsules, and the last couple of days it's improved the amount that I can urinate before catheterization.
Yeah.
So, yeah, I'll follow up with Dr. Davis and a local urologist.
Your local guy, yeah. I mean, definitely. I wish we could help you more. Anybody else have any suggestions at all? Okay.
Okay, thanks.
Sorry we can't be more helpful to you. We've lost Dr. Paul, who would have been very good on this one. And we don't have. Okay.
I'll follow up.
Okay.
Next time. Thank you.
And last but not least is Dan M. in Schenectady. What's on your mind?
Um, I have the same problem with fatigue. I had COVID about like 4 weeks ago, and I haven't been able to regain my energy level. Well, I gained some of it back. I do water aerobics Monday and Wednesday, then I go to gym Tuesday and Thursday. And like she said, I got a half a day of good energy. By midday, I'm kind of zonked. I was wondering, do you have, and you mentioned the Wellbutrin and Redlin. I'm looking at that. Is that, well, is there any other thing I can do to regain my energy levels?
Yeah, but Dan, you had COVID 4 weeks ago.
Yeah.
And with Richard Fisk, and we're talking about much more of a long-term problem. And I mean, to dive into Wellbutrin and Ritalin and anything else that was suggested when you're less than 4 weeks out of COVID. I mean, we know people that have been nailed by COVID for a long time. So my gut reaction is you got to give the COVID some time to clear your system. But let me throw this one out to other people in the group. Anybody who's had COVID want to talk about how long it took you to recover your wellness?
I had a case of COVID for the first time. I think it was about a year ago. And I would say it took me about 6 months to recover, Dan.
Okay. All right. All right. And another quick question. I was reading the article about PCPEP, that study there. And so they mentioned that you can do a part of that study, but I was wondering, how do you have to enroll in it to do part of it? Because I was actually interested in the dietary piece of it.
Yeah, I don't think you can pick and choose. I think you have to enroll in the study, which the link is there. And if you don't conform with all the other stuff, then you can tell them, well, I was really only interested in the diet. I wouldn't go in saying this is all I'm interested in, but I would say that, that's between you and PCPEP.
Okay.
But it's not like you have to do this stuff. I mean, we've had a couple of guys enroll. Steve Logan, are you still with us? Did you leave? I think he left. No, Steve Logan. Steve Logan enrolled, and trying to think who else. But yeah, I mean, could be a very helpful program to a lot of guys. We've had some active surveillance people. It's open to anybody with a diagnosis.
Right. Is it similar to the Live Strong program?
No.
Okay.
No, the Live Strong program is an exercise-only program for 16 weeks where you show up in the gym and they help you figure out your right exercise. This is a survivorship program. It looks at nutrition, exercise, stress management, Kegels if you're having any issues with incontinence or erectile dysfunction. Oh, okay. Tell us, Dr. Pierre, tell us how it's been so far, and tell us your thinking.
Yeah, I've only been on it for a week. If you're willing to commit the time, I think it's well worth it. And I've found it real helpful for the Kegel exercises because they actually have a little bit more intensive treatment than I was doing, and I've noticed some changes in just a week. Basically, I mean, I was improving, but not as fast as I would have liked, and I think it's good. The only caveat is their heart monitor thing, which is the other thing I was looking forward to. They can't ship it out of Canada for whatever reason. I don't know if it's financing because they're on a grant or whatever. So you basically have to put your finger on the camera of your phone, and it measures your pulse, 500 times a second or something like that. And but in order to do that, I was able to do it one episode basically, so I know what it is. But then you have to pay, so I contacted them, and they said they would get authorization so I could get it, but it would take 3 weeks.
Okay, thank you. So beware of heart monitor issues if you're in the US. They should really, they need to work that one out because they've got so many men in the US.
I agree.
All right. Yes, Larry, you have your hand up.
Yes, the Live Strong program I went through also included membership in the Y. Cost me nothing, and you get a discount if you sign up for later.
Right. Yep. Because I just started that Tuesday, so Thursday will be at my first formal meeting. Yeah.
Okay, it's a great program. You'll get a lot out of it. It's good to hear that you've signed up for it. I'm very pleased. All right. Well, we are through. I thought it would be a longer meeting. We got through pretty quickly. Sorry we missed a couple of guys. Anybody here got anything they want to raise before we sign off? And if not, we'll see you all next Tuesday. Dr. John should be in the chair. I think he will be in the chair. And we'll see you all then. Joe Siri just sent me a message, but he meant to send it to you all, and it says, "Thanks to all of you and be well." That was for everybody, not just for me. So I'm just relaying the message, and we'll see you all in 9 days. All right.
Take care, Rick, everybody.
Hey.
Thank you.
Good night.
Good night.